So common things is always common as far as the specialty is concerned. But as far as neurosurgery is concerned, the uncommon things is always is common for us. Okay, so always keep in mind a spontaneous acute STH. The commonest cause is posterior communicating artery aneurysmal rupture, the dural AV fistula, and then AVM. So which one of the following is most likely shown in the image below? Arachnoid cyst, cavernous sinus hemangioma, meningioma, craniopharyngioma, giant MC aneurysm, pituitary macroadenoma. So what do we see here? Yes. What do we see here? What is this? Okay. Any guesses? Okay. So I will tell you. So what we see here is this is a giant MCA aneurysm. Okay. So this is a giant middle cerebral artery aneurysm. So what we see here is some T2 hyper intensity. And what we see here is the flow voids. So this is the thrombus. Okay, this is the intraluminal thrombus in the aneurysm. And these are the flow voids which we see. So this is a case of a giant MCA aneurysm. Okay, this is a giant MCA aneurysm. So this is a 46-year-old female presenting with sudden onset of right facial numbness, hearing loss, and diplopia. CT head was unremarkable. Which one of the following therapies may be most appropriate based on the subsequent imaging shown? So we can start either anticoagulant therapy, balloon angioplasty, intraarterial nimodipine, surgical clipping, and thrombolytic therapy. So what do we see here in this image? So this is a patient presenting with facial numbness, hearing loss, and diplopia. What is the diagnosis here and what treatment are you going to choose? Can you tell me what is the diagnosis first? What do you see here? Is there anything unusual you see in this image? Okay. So due to, as the meeting is going to be concluded in 6 minutes, so I myself will explain this. So what you see here is, this is a vertebral artery dissection. Okay. So you compare it with the opposite side. What you see here is a vertebral artery dissection. So as a result of hypertension, so the common cause of vertebral artery dissection is, it's always trauma, but when it is a spontaneous, hypertension is one of the commonest cause for such dissections. So that is why it is presenting with all the brainstem features like facial numbness, hearing loss, and diplopia. So the treatment of choice is going to be anticoagulant therapies. So the MRA shows a spontaneous right vertebral artery dissection. So the main treatment is going to be the anticoagulation or antiplatelet therapy. So what do we see here? It's a 37-year-old man presenting with seizures. So which one of the following is not thought to increase the risk of hemorrhage in this type of lesion? So first, what is the lesion here? What is the lesion here? See, we are seeing here. Okay, no guesses. Let us make it more interactive. Doesn't matter even if it's wrong. Okay. So what we see here is an AVM. Okay, so this is an AVM. So a detailed analysis on the AVM we will be discussing in the subsequent sessions about what is Spätzle-Martin grading, what is the modified Spätzle-Martin grading, how what is the treatment strategies for brain arteriovenous malformation. So here I'm just trying to give in a nutshell about all the a clinical picture with radiological correlations. So brain AVMs are abnormal vascular anomalies within the brain, presumably congenital in nature, but tend to present later in life. There are several subgroups, including the glomerular and fistulous types of AVMs. The AVMs, often bile-based, they are defined by the presence of arteriovenous shunting through a nidus of coiled and tortuous vascular connections that connect feeding arteries to draining veins without a capillary bed. So most of the AVMs are located in the cerebral hemispheres. 11 to 18% is located within the cerebellum, and 13 to 16% in the brainstem, and about 8 to 9% are deep-seated. The presence of intracranial hemorrhage indicates a poor prognosis, and it is associated with an increasing morbidity and mortality. The presence of AVMs can lead to arterial stent phenomena, venous congestion, gliosis, and hydrocephalus. The factors that increase the risk of hemorrhage from an AVM is the history of hypertension or previous hemorrhage, the flow-related intranidal aneurysms, the deep venous drainage, the periventricular location, the size of the nidus when it is less than 3 centimeter, when you have a high feeding artery pressure, and when there is a slow arterial filling, and when there is a venous stenosis. So this is a question based on some percentage. So it's a 54-year-old woman presents with sudden onset severe headache. Her GCS is 15/15 with no neurological deficit on examination. The rupture of a vertebrobasilar aneurysm is thought to be responsible for the imaging appearances shown in what proportion of cases. So the answer is 6%. Okay, so what you need to know is the non-traumatic, non-aneurysmal perimesencephalic hemorrhage. Okay, the non-traumatic, non-aneurysmal perimesencephalic hemorrhage. So this is what it is being shown here. Okay, this is called perimesencephalic hemorrhage. So this is usually non-traumatic and non-aneurysmal. Okay. So it is presumably of venous origin, and it accounts for 96% of all perimesencephalic hemorrhages. The remaining 4% has been reported to come from the rupture of the vertebrobasilar artery aneurysms. The non-traumatic, non-aneurysmal perimesencephalic hemorrhage is characterized by relatively mild symptoms of onset, confinement of the extravasated blood in the perimesencephalic systems, and absence of an aneurysm on angiogram. So it has a benign clinical course and excellent prognosis. So this is a non-traumatic or this is a case of a perimesencephalic hemorrhage.